Thank you for joining my lecture on Chapter 11, The Senses, which can be found in the Human Body in Health and Disease text by Patton and Thibodeau. Born in 1932, Tom Robbins is an American writer of some warm, wise, and wonderfully weird novels, including books like Still Life with Woodpeckers, Jitterbug Perfume, and Fierce Individuals Home from Hot Climates. In an excerpt from Wild Ducks Flying Backwards, he writes this: "Are you ready for new urban fragrances? I want to travel on a train that smells like snowflakes. I want to sip in cafes that smell like comets. Under the pressure of my step, I want the streets to emit the precise odor of a diamond necklace. I want the newspapers I read to smell like the violins left in pawn shops by weeping hobos on Christmas Eve. I want to carry luggage that reeks of the neurons in Einstein's brain. I want a city's gases to smell like the golden belly hairs of the gods. And when I gaze at a televised picture of the moon, I want to detect, from a distance of 239,000 miles, the aroma of fresh mozzarella." There has been some debate about how many senses there really are, but most scientists and experts agree that there are 5 senses, and those senses are taste, touch, smell, hearing, and sight. And those major sense organs that we're going to talk about today are the eyes, the ears, the nose, and the taste buds. You know, all of these sense organs work together to help us gain an understanding of our environment. And I didn't realize how much my ears help me to see until I lost the hearing in one of my ears. And then I really became aware of how all of these senses work together to give us a holistic understanding of our environment. And these sense organs, they have different types of nerve endings. 2 different types specifically are categorized as uncapsulated, which means they don't have a capsule, they're free or naked at the end, and then encapsulated nerve endings. Uncapsulated or free nerve endings are primarily found in the skin and the mucosa and those epithelial layers of those tissues. And the remainder are capsulated nerve endings. So those are some that we've talked about before, like the Pacini corpuscle, the Meissner corpuscle, and the Ruffini corpuscles, which are all located in the skin. And then there are other types as well, which you really don't need to know the exact ones, just to have an understanding of that there are these 2 basic types, uncapsulated and encapsulated. These sensory receptor cells are classified functionally by the types or modes of stimuli that activate them. And there are 5 major types that the book talks about, and I have highlighted them here on this chart. The first one is photoreceptors. And photoreceptors are responsible for the changes in light and for color in our vision. Chemoreceptors are sensitive to the presence of certain chemicals in the taste or in smell. Thermoreceptors are sensitive to changes in temperature, and mechanoreceptors are sensitive to mechanical stimuli that change their position or shape. And then lastly, which is not on this chart, the book talks about pain receptors, which are sensitive to physical injury. So make sure you know the definitions of these and you can distinguish between them. All sense organs, regardless of size, type, or location, have some common functional characteristics. All of them are able to detect a particular stimulus and then convert that stimulus into a nerve impulse that gets sent to our brain. So an example could be the eye. The eye has sensory receptors that are rods and cones, which are photoreceptors, And the eye takes that in, and the image is reflected on the very back of the eye called the retina. And the retina is attached to the optic nerve. And that optic nerve turns that image into an electrical signal, and that gets transferred to the occipital area of the brain. While sense organ receptors are found in every part of the body, they are the most concentrated in the skin. And predominantly, as I said before, the unencapsulated receptors are located in the skin, the free nerve endings, and they're responsible for detecting pain, touch, tickle, and temperature. Meissner's corpuscles are responsible for tactile touch. That's a very fine or light touch or vibration. And then the Ruffini's corpuscles and the Pacini corpuscles are responsible for detecting deeper pressure and vibration. And then lastly, Krauss is also responsible for detecting touch. So in our previous lecture, we talked about muscles and how there's that knee-jerk reflex that is initiated by stretch receptors. And here we learn that stretch receptors are also referred to as proprioceptors. And when they are stretched, then receptors provide us with the information concerning the position or movement of those different body parts. So the Golgi tendon receptor is responsible for proprioception, and the muscle spindles are also responsible for proprioception. And as we talked about, there's superficial receptors and there's deep receptors, and those deep receptors are responsible for sensing stretch, and also sensing chemicals like detecting levels of pH, carbon dioxide, and other types of chemicals. There are several ways that the general senses can be disrupted, and one of the ways is through third-degree burns. Third-degree burns can completely destroy general sense receptors throughout that affected area, and this can result in a loss of pain and touch sensation. Also, have you ever been sitting in a certain way or lying in a certain position and pretty soon you can't feel your hand or you can't feel your foot? This is because there's been a reduction in blood flow to that extremity, and so this can temporarily impair the general senses because of the lack of blood flow or the slowing of the blood flow. So once you kind of change that position or you get up and walk around a little bit, it may start to tingle as that sensation comes back and that blood flow is restored. Some other situations that can cause a disruption in the functioning of general sense organs could include diabetes, peripheral vascular disease, cardiovascular disease, stroke, and or brain and spinal cord injuries. One of my favorite sensory organs to talk about is the eye. I think the eye is just so amazing. Did you know that the eye processes approximately 36,000 bits of information per hour? Also, one of your eyes consists of 2 million working parts. Isn't that amazing? So the eye is the sensory organ of sight, and it is protected by a myriad of bony structures. And you can see how this socket, the eye socket, really protects that very sensitive sensory organ, the eye. And the eye is responsible for converting light energy and sending that information on to the brain into the occipital lobe where it can be interpreted and processed. So there are no less than 7 bones that make up that bony socket of the eye, and that's the frontal, the sphenoid, the ethmoid, the superior maxillary, the zygomatic, which is the cheekbone or malar bone, the lacrimal bone, and part of the hard palate. The eye consists of 3 layers, and those layers are the fibrous tunic, or the outer layer, the vascular tunic, which is the middle layer, and the nervous tunic, which is the deep layer. So the fibrous tunic consists of the sclera and the cornea. The vascular tunic consists of the choroid, the iris, and the ciliary body, and the nervous tunic consists only of the retina. So we're going to talk about each of these parts in detail coming up. You may have noticed when you were studying the cranial nerves that there are 4 cranial nerves that are devoted to the operation of the eye. And only one of those, the optic nerve, which is the second cranial nerve, is responsible for vision. The other 3 are responsible for movement of the eye, which tells me that this is a very intricate process. The oculomotor, trochlear, and abducens are all responsible for movement of the eye. And here you can see the different muscles that I've listed that are referred to as extrinsic muscles, and they are meaning like external on the outside of the eye, and they attach to the bony orbit, and you can see how each one is responsible for a certain type of movement. Now, if you can imagine that line where I've listed midline as your nose, then the arrow either going towards or away from the midline or the nose will give you an indication of the movement. So it's a very intricate process, the movement of the eye. So what happens if the eyes aren't aligned properly? There are different situations, whether they could be cross-eyed or wall-eyed, so the eyes are tracking towards the midline or away from the midline, or that wandering eye, they sometimes call it. So if this is the case, then we can perform a surgery called a strabismus. And strabismus procedure is the realignment or the proper alignment of the eye. And the way that we do this is by shortening or lengthening those extrinsic muscles of the eye to bring the eye back into proper alignment. The body has a very specialized way of nourishing and bathing the eye, and that is with the lacrimal system. And the lacrimal system consists of glands, ducts, canals, and the lacrimal sac. The lacrimal gland is located right here on the superior lateral orbit of the eye, and it is responsible for manufacturing tears. And the ducts are these little guys that you can see coming down here, right? And these ducts live in the eyelid. These are the lacrimal ducts that carry the tears from the lacrimal gland to the eyeball itself. And then there are the lacrimal canals. And the lacrimal canals are right here, and the lacrimal canals are responsible for draining those tears. So if you've ever wondered why, if you cry and your nose becomes a runny nose, this is why. Those lacrimal canals drain those tears right into the nasal cavity, right? And through that lacrimal sac there. So you can see how it comes out laterally and then it drains medially. So something that can happen if those lacrimal canals get clogged is something called dacrocystorhinitis. And to fix that, we perform a procedure called a dacrocystorhinostomy, or a DCR for short, where we open up those clogged canals and we put a little rubber straw, a tiny little tube in there to keep those canals open and patent. So now we're going to go ahead and talk about each component each structure of the eye in a little bit more detail. The sclera and the cornea form the external tunic, and the sclera is covered by a thin mucous tissue referred to as the conjunctiva. The conjunctiva lines the eyelids as well as covers the sclera. And these vessels that you see in this picture here, those are actually vessels in the conjunctiva. And the conjunctiva is nourished by the lacrimal glands and the tears that they produce. Now the sclera, like I said, is very fibrous and thick. It's that white part that you see, and it helps to maintain the shape of the eyeball itself. The posterior portion of it is opaque. The anterior portion is transparent, and it is covered by the cornea anteriorly. And it also contains ciliary nerves and vessels within its tissues. The cornea is a dome-like structure that covers the front or the anterior surface of the eye, and it serves several purposes. One, it helps to protect the eyes from germs, dirt, and harmful substances, and it also allows light to enter the eye. It's very clear, it's very smooth, and it doesn't have any vasculature. It is only an organized group of cells and proteins, and it receives its nourishment from those tears that we talked about. And it is broken down into 4 layers, which you don't have to know the 4 layers. The cornea actually contributes to 65 to 75% of the eye's total focusing power, and if the cornea becomes diseased, then that can significantly impair sight, which is the reason why corneal transplants are the most common organ transplant in the United States. Have you ever wondered why cats' eyes glow, but we get red eye? The reason is because cats have something, and other animals as well, called the tapetum lucidum, which is a very reflective surface that does not have melanin. And that's why a cat, when light captures its eye, can look like it's glowing. Humans, on the other hand, have this very pigmented layer in their eye called the choroid. And it is pigmented because it contains many blood vessels, and these blood vessels help to nourish the eye. It is also pierced at the back of the eye by the optic nerve, and it is sandwiched between the retina and the sclera. The ciliary body is a thin vascular layer that's located between the sclera and the retina. Its job is to release aqueous humor, which is a fluid that is in the anterior cavity of the eye. It also houses the ciliary body, which is an intrinsic muscle. So we talked about extrinsic muscles being on the outside of the eye. This is an intrinsic muscle, which is on the inside of the eye. And the job of the ciliary muscle is to change the shape of the lens to allow us to focus on objects. The iris gets its name from its Greek translation, which means rainbow, and it is the colored part of our eye. It is a muscle, and there is an opening in the middle of it called the pupil. It is circular in shape, and it serves as a demarcation between the anterior chamber and the posterior chamber of the eye. So we're going to talk a little bit more about these cavities of the eye, but the eye is broken up into 2 cavities, an anterior cavity and a posterior cavity. And the anterior cavity is divided into 2 chambers, the anterior chamber and the posterior chamber, and the iris divides those 2 chambers. Interestingly, when we have a dark brown eye, that is because it has increasing pigment, and the less the pigment, the lighter the color of the eye. So very little pigment, we're going to get a blue eye, and no pigment at all, we're going to get a pink iris. Here we get a look at the pupil, this very dilated eye. The pupil can be dilated to a size of nearly 9 millimeters, and it is similar to the aperture of a camera. It opens and closes to regulate the amount of light that enters the eye and hits the retina. Have you ever been in a movie theater and it's very dark in there and you come out and it's the middle of the day and your eyes, you just want to close them tight really quickly because the amount of light that is entering your eye is almost painful? That's because in the dark or darker environments, our pupil dilates so that it can let in as much light as possible. So that's why when you are in a dark room and then you go out into the light, that your eyes are sensitive to the light for a time. It takes a little bit of time for that pupil to adjust and accommodate. Now here we are at the retina. The retina is the nervous layer of the eye, and it's the innermost layer of the eye. It lines the entire back of the eye, and it is continuous with the optic nerve. And this is how signals travel to the brain. They land on the retina, and they travel through the optic nerve to the occipital area of the brain, where they are turned right side up and processed. The retina consists of two types of photoreceptors, and those are rods and cones, and we're going to look at those on the next slide. So here we are, as promised, the photoreceptors, two different types, rods and cones. Rods have long, thin light projections, and there's quite a bit more of them than there are cones. About 120 to 130 million rods, and they increase in concentration in the periphery of the retina, so more along the outside edges, and they're important for seeing shades of gray. Cones, on the other hand, are responsible for seeing color, and the way I remember this is C for cone and C for color. And there's approximately 6.5 to 7 million of those, and they have 3 different pigments that combine each other to allow us to see millions of colors. When we have photoreceptors that are absent, we have photoreceptors that are absent at the optic nerve. So there are no photoreceptors there, and that is referred to as the blind spot. So if somebody's ever standing like just out of your sight, then that is that area of the blind spot where there are no photoreceptors in the eye, and that's where the optic nerve pierces the retina, or pierces the back of the eye rather. A lack of cones can lead to color blindness, which is more common in males because it is linked to the X chromosome, as I discussed before, how in females, if there's a trait on one X but there isn't a trait on the other X, it would be masked. But in males, it's not masked because there's only one X, so therefore it's more common in males. The lens of the eye is really amazing. It is purely made up of proteins, and it's enclosed in a collagen capsule. I kind of like to think of it as like a peanut M&M, where that collagen capsule is the shell, and then there's kind of a softer inner portion, and then there's a more solid core in the center. The Greeks believed that the lens looked like ice in appearance, and so they gave it the name crystalline. It lies behind the pupil, and the ciliary body that we talked about before that houses that ciliary muscle attaches to the lens, and it is what helps to, like I said, help us to focus. It's going to be changing the shape of that lens. The lens also helps form the posterior chamber, which is in the anterior cavity of the eye, and it retains all of its cells for an entire lifetime. So what this means is if we live long enough, by the age of 75, a majority of us are going to have cataracts because these cells never replicate themselves and we retain them for our entire life. So our vision is at its highest acuity when we're born, and it just goes downhill from there. All right, I'm going to give you the words about the cavities of the eye, and then we're going to look at an image. Like I said before, there are two cavities, the anterior and the posterior cavity. The anterior cavity is broken up into two chambers, the anterior or front portion and the posterior or back portion. The anterior cavity is filled with aqueous humor. Again, I remember that by anterior starts with A and aqueous starts with A. So it helps me remember that the fluid in the anterior cavity is aqueous humor. Remember, it's produced by the ciliary body. The anterior chamber is in front of the iris. Remember the colored part of our eye. So the anterior chamber is in front of the iris and it's behind the cornea. All right, so it's between cornea and iris. The posterior chamber is behind the iris and in front of the lens. The posterior cavity then lies behind the lens, and it is filled with a fluid called vitreous humor. And while the sclera helps to maintain its shape, the vitreous humor helps to maintain the pressure within the eye. Okay, so here we are looking at a side view of the eye, and let's first talk about the posterior cavity. It seems like that's the easiest to understand. So I'm just going to trace, I'm going to try to trace, it's kind of a little bit difficult. Behind the lens, this whole area here is the posterior cavity. Alrighty, now that is filled with the vitreous humor like we talked about. Now let's talk about the anterior and posterior chambers. So this is within the anterior cavity. This entire, let me get it different. We're going to do it in green. So this entire area in front of the lens, right here, and behind the cornea. This entire thing is called the anterior cavity. So we said that the anterior chamber is in front of the iris. So let's see, let's make the iris blue. That's this red thing right here. All right, this is the iris. Okay, so in front of the iris, this space right here, that's the pupil. All right. So in front of the iris and behind the cornea, that is the anterior chamber. Now the posterior chamber is very small, don't miss it. It's behind the iris and in front of the lens. So it's this little space I'm drawing in blue right here. Okay? Behind the iris and in front of the lens. I hope this helps. All right, let's talk about the visual pathway. Is this not interesting when you look at this image that the left eye goes to the right side of the brain and the right eye is interpreted by the left side of the brain? Isn't the human body amazing? So what happens? Light enters our eyes and it hits the back of the retina, which is called refraction. And at this point, the image is completely upside down. It's upside down and it gets transmitted through electrical impulses or nerve impulses, right? And it travels to the visual cortex of the brain, which is located in that furthest back part of the brain, in the occipital lobe. And there it is processed, turned right side up, and that is the process of seeing. I'm sure all of us at one time or another have gone to the optometrist and had our eyes examined, and there are a variety of different instruments that they can use to examine the eye, but we're going to talk about some disorders of the eye. First up, we're going to talk about refraction disorders. There's myopia, hyperopia, astigmatism, and cataracts. So first off, myopia. Myopia, you might have heard it referred to as nearsightedness. This is often caused by an elongation of the globe of the eye, whereas hyperopia or farsightedness is often caused by a shortening of the eyeball. And what happens, you can see in this image here with myopia, it's uncorrected and this image is falling short, too short, right? Because the eyeball is too long. The image isn't landing where it should. And then with hyperopia or farsightedness, the eyeball is too short. Okay, so how we can correct that is through corrective lenses, glasses, those kinds of things. You know, there's also LASIK surgery that can be done to help correct those things, and it has to do with adjusting how refraction occurs through the cornea. And astigmatism is a distortion that is caused by an irregularity of the cornea or the lens. And then lastly, cataracts are these cloudy spots in the lens. Like I said before, the cells of the lens, they never replace themselves. And so they age with us. They're same ones that we were born with. And as we age, the propensity for us to develop cataracts increases. Other eye disorders can be as a result to some sort of infectious mechanism. Chlamydia is one, which is called trachoma, which is a chronic chlamydial infection. Because of this, in infants, it is now the standard of care. As soon as the baby is born, because it does pass through the vaginal canal, that we put antibiotic ointment in the eyes as a standard of care to prevent trachoma. Acute bacterial conjunctivitis, if you've ever had pink eye, that's what we're talking about. It's highly contagious, and it produces this discharge of mucus, and the eyes get really crusty. It feels like there's sand in your eye. If you've ever had pink eye, you know that is not fun time. Conjunctivitis can also be caused by allergies as well. Now let's talk about some disorders of the retina. Something that can happen with trauma to the eye is retinal detachment, and it can also be a complication of aging or tumors, but a lot of the time we see it with trauma to the head or the eye. Diabetic retinopathy is damage to the retina from hemorrhages and also growth of abnormal vessels associated with diabetes mellitus. Glaucoma is an increased intraocular pressure because of an increase or an overproduction of aqueous humor. And then nyctalopia is referred to as night blindness, or the inability to see in dim light, and is caused by the degeneration of the retina, or it can also be caused by a lack of vitamin A. Eat your carrots. As we age, something can happen called macular degeneration. The macula is the area on the retina that is the most concentrated with those photoreceptors. And over time, it can start to degenerate just because of the aging process and our exposure to environment, so on and so forth. And then color blindness. Most forms are inherited. Like I said, it is an X-linked genetic condition, and it causes an abnormality in the cones, those photoreceptors that are responsible for seeing color. And if you can see these numbers here, 74 and 42, this would mean you are not colorblind. If you have difficulty making out what these numbers are, that could be an indication of colorblindness. Two common disorders of the visual pathway could be scotoma, which is common in patients with multiple sclerosis, and also cerebral vascular accidents. So strokes can also cause this blindness just in that center focal field, visual field. So the stimulation or trigger that activates receptors involved with hearing and equilibrium is mechanical. And therefore, the receptors themselves, we refer to them as mechanoreceptors. Hearing is transmitted through vibrations that enter the ear, and they make their way to the auditory nerve, which then makes its way to the brain to interpret the sounds, the vibrations, as hearing. Now, there are three different parts of the ear that we're going to talk about: the external ear or outer ear, the middle ear, and the inner or internal ear. All right, let's talk about the external ear or the outer ear first. Now, the part that we see of the ear, this outside cartilaginous area, is called the auricle or the pinna. It's the visible portion, and it's responsible for capturing sound or vibrations. Have you ever been trying to hear something and you kind of cupped your hand behind your ear? That's helping to increase that job of what the pinna typically does. The external auditory meatus is the opening. Like if you could stick your finger in your ear, you would be putting it into the external auditory meatus, and it extends from the pinna or the auricle to the tympanic membrane or eardrum. The external auditory meatus is S-shaped, and it's about 2.5 centimeters in length, and it also has some glands that live there, and they're called ceruminous glands, and the job of these glands is to secrete cerumen, or what we typically refer to as earwax. Here you can see the tympanic membrane. It's this concaved tissue or eardrum, we refer to it sometimes, and it's semi-transparent, and this is like from the outside looking in, and it separates the external ear from the middle ear. At its point of maximum concavity, we refer to that point as the umbo. And on the other side of it, the first little bone of the ear, called the malleus, rests against that tympanic membrane. Now, this is how sound is going to be transmitted via vibrations through the middle ear and external ear to the nerve and then to the brain. The middle ear extends from that tympanic membrane or eardrum all the way to the wall of the middle ear cleft. It is filled with air, so really nothing is in there except for three little bones: the malleus, the incus, and the stapes. And you can see them over here. Let me circle them for you. The malleus, the incus, and the stapes. They're right there, and they're three of the smallest bones in the body. And what happens is sound is going to come into the ear, it's going to hit the tympanic membrane, and it's going to cause a vibration. That vibration is then transmitted through the malleus. It's touching the incus, so it then travels through the incus, and it's touching the stapes. It travels through the stapes, and the stapes rests against something called the oval window, and then that's going to be transmitted through the inner ear and then eventually to the auditory nerve. So those three little bones are called ossicles, and they have two different names, each of them. The malleus is also referred to as the hammer, the incus also referred to as the anvil, and the stapes also referred to as the stirrup. The inner ear has two main sections, and that's the paralymphatic labyrinth or bony labyrinth, and it is filled with a fluid called paralymph. And then the membranous labyrinth consists of three main components: the cochlea, the semicircular canals, and the vestibule. And so the cochlea, we also refer to it as the snail. You can see it right there. It's the organ of hearing. And then these semicircular canals are kind of the roller coasters of the middle ear, and the entire middle ear is filled with fluid. And inside these structures are these tiny little hairs, and they are referred to as cilia. Remember, we've talked about that before. And so in the cochlea is the organ of Corti, and it is lined with cilia. And the cilia also assist in vibration and conducting that signal that was received from the external ear to the auditory nerve. Now, the semicircular canals, they're responsible for equilibrium. So if you're feeling dizzy or out of sorts, you can blame your semicircular canals. Not only do they communicate with the middle ear, but they live inside the temporal bone, and they contain endolymph. Again, just a fluid that is filling that area. And then the vestibule is made up of two membranous sacs, and they're called the otolith organs, and these are responsible for helping us know where we are in the universe, right? Know our position. Are we upright? Are we laying down? Those types of things. So let me walk you through the transmission of sound. First, we hear something, and that sound is transmitted via waves through the external ear to the eardrum. All right, so those sound waves cause the eardrum to vibrate, like I mentioned previously, which is conducted through those three little bones. Those three little bones amplify those vibrations and conduct them to the middle ear. The stapes rests on that oval window, which is located near the cochlea. And so those vibrations hit the cochlea, and it is lined with those tiny little hairs, and those hairs then begin to move and vibrate, and neurotransmitters are released. Now here comes the part. Remember, we talked about the nervous system and how neurotransmitters are very important in transferring an electrical signal. So at this point, those vibrations are turned into electrical impulses, and they travel down the auditory nerve into the brain, where they're interpreted as hearing. As with our eyes, and how most of us have probably been to the doctor to have our eyes examined, we've probably also had our ears examined as well. So that's not something that's foreign to us. Typically, they use something called an otoscope to look into the ear, and they can only look as far as up to the tympanic membrane. And here you can kind of see a close-up of the tympanic membrane, and maybe you might be able to see the malleus right here, this line that is on the other side of that membrane. So what happens when something goes wrong with the ear? There's two different types of disorders: conduction impairments and nerve impairments. Conduction impairments can be caused of a variety of things. One can be a blockage of the external or middle ear. This can be caused by some sort of growth, either a soft tissue growth or a bony growth, or earwax, which we refer to as cerumen. Otosclerosis is characterized by the hardening of those tiny little bones, which prevents them from vibrating as efficiently as they should, thus is going to result in reduction in hearing. Sometimes it can appear as noise or tinnitus, ringing in the ear, and progress to hearing loss. And then otitis is typically due to some infectious mechanism. It causes an inflammation in the ear, and it can produce swelling and excess fluid that can block sound conduction. And then nerve impairments. Progressive nerve deafness can result from chronic exposure to noise. Also, as we get older, we have a tendency to have degeneration of our hearing, and that is called presbycusis. So previously I mentioned the vestibule and the semicircular canals and how they work together to maintain our equilibrium. So the vestibules are two structures, and they're made up of these hairs that have this thick coating of gel. And this, each of these structures is called a macula. And so when you move your head, gravity is going to pull on those hairs, and that gets interpreted in your brain as your sense of gravity or static equilibrium. The three semicircular canals are oriented at right angles to one another, and there's these little dilated areas within those canals called the ampulla, and the ampulla contain the sensory structures called the crista ampullaris, and their job is to generate nerve impulses which detect the speed and the movement of our head. And this sense of motion we refer to as the dynamic equilibrium. Within the semicircular canals that are filled with endolymph, and so as we move our head, that endolymph moves, and that causes other structures within the ear to move, which helps us to our brain to determine our direction of movement. Now, the vestibule and the semicircular canals, the mechanoreceptors, join to form the vestibular nerve, and that vestibular nerve eventually joins with the cochlear nerve, and they call that the vestibulocochlear nerve, which then becomes the auditory nerve that transmits those signals to the brain. So if something goes wrong, we're going to experience dizziness with an equilibrium disorder. It could cause falling, it could cause lightheadedness, nausea, vomiting. Sometimes that is caused by an infection or an inflammation in the ear. There's also an equilibrium disorder called Meniere's disease, and it is a chronic inner ear disorder, and it is characterized by tinnitus or ringing in the ear, nerve deafness, and vertigo, which is dizziness.